Evening, everybody. My name's Laura. I'm here to welcome you to the University of Huddersfield. We have a series of public lectures which are always held in the evening, and we go through lots of different topics all through applied sciences. So we've had geography, biology, optometry, all sorts of different things. And tonight we have pharmacy with Nicola. So Nicola's research builds bridges between healthcare and other disciplines like public health and education. As a foundation for advocacy activities that increase health and well-being for children and young people. She's raised the profile of young people as a focus for pharmacists. Nicola's studied the information sources used by young people when they have a health problem and was one of the first in the field to write about online health information. She brings professionals together to explore opportunities for better intersectoral working to promote well-being in schools. Nicola is currently the co-chair of the UNESCO Chair Global Health and Education in partnership with Professor Didier Jourdain at the University of Clermont-Auvergne. Not sure if I said that right, but I tried, in France. And there's a little known fact about Nicola. She was the first person to use PowerPoint at the British Pharmaceutical Conference back in 1995. And the Pharmaceutical Journal reported it and said it all worked perfectly. And she hopes that it will all work perfectly tonight. So I welcome you, Nicola.
That is my most prized thing. So what we're going to talk about tonight is a subject close to my heart, and we've talked about it. Any of you who are here for the panel discussion of the UNESCO Chair Global Health and Education this afternoon would have heard us talking about health literacy, and it's something that has occupied me for almost 25 years now. I'm going to tell you a little bit about the UNESCO Chair firstly, and then I'm going to tell you about my journey with health literacy and indeed where I think the health literacy is going. So a little bit about me. I'm a pharmacist. I am a community pharmacist by background, but I also have hospital and academic experience. My PhD and my postdoc was in young people's health. I kind of fell into it. I was really interested in where people got their information from before they came to me as a community pharmacist. You know, bits of the newspaper and did you see that advert last night? So that was how I fell into it. I then got the opportunity to do a very exciting postdoc fellowship in Rochester, New York, one of the coldest parts of the USA. I chose really well there. And a long career later, I find myself at the University of Huddersfield, a fantastic academic home for me. And I am a reader in medicines and health. I'm a fellow with the Royal Pharmaceutical Society, very proud of my professional background. And I'm also a fellow of the US Society for Adolescent Health and Medicine, which I'm equally proud of. I currently hold a role as the Vice President for Europe of the International Association for Adolescent Health, and I'm a trustee of the Association for Young People's Health. And any of you who have been here for the day will know that they're fantastic young leaders were there with us this afternoon. A little bit of history about the UNESCO Chair then. So I met Didier from the University of Clermont-Auvergne at an IAAH European meeting in Moldova, of all places. Great wine, a great place to go and visit. I have to say, there may be a coincidence there that he told me that 1 week later he was launching this UNESCO Chair in Global Health and Education. I joined the steering group at that time of the chair as in my International Association for Adolescent Health role. And I was an affiliated researcher in his group doing really interesting survey work during the pandemic. But as the next mandate approached, because they give you a mandate for 4 years at a time from UNESCO, we thought actually it might be a great idea to apply jointly, because that kind of personifies the mission of the chair, which is to look at intersectoral working between healthcare, public health and education. So I bring the healthcare and Didier brings 2 PhDs and a medal, but basically public health and education background. And I know he's online and he's probably throwing things at the screen at me as I speak, but it's true. He's a very impressive person, those of you who've met him. Now, we were very blessed to go to UNESCO headquarters in Paris last month, and with our Vice Chancellor, Prof. Bob Crine, you can see there, the lady standing to his left is Anna Nzabuga, and she is the UK ambassador to UNESCO, the permanent delegate. And she was very generous with her time. You can see Barbara there, Somto, fantastic PhD student, myself, and Jim Reed, and, you know, fantastic colleagues from Huddersfield. And, you know, I think it was, you know, a milestone moment for me. There's a few other photographs there. You can see Didier, he's a bit taller than everybody else in the middle of the panel. Those who know him are laughing, I know. And you can see the VC and others there enjoying a really special day for us with WHO and UNESCO colleagues at UNESCO headquarters. One of the really strong themes in our second mandate, although it was there in the first, is about the future and developing young leaders. And these are just some of the young leaders that we have. Is Somto still in the room? She absolutely is. Somto should be bang in the middle there, shouldn't you, with the young leaders. Somto has taken part in many of our activities, but worldwide, these people are precious to our mission. And we also have the older generation. We have our national representatives. So we have 8 colleagues there out of 30 or more than 30 stars across the world who have committed to our mission and who are active in our research or in our practice work or in developing teaching programs. And it is an honour and a pleasure to work with them. So I was explaining to you know, that we have 4 flagship programmes of work for this next period that we are looking at. If I go clockwise from top left, extending health promotion practices in community health settings. Of course, pharmacy is very close to us and we have a good network. We are starting there, but we've had colleagues with us in primary care and we would love to extend that work to optometry and to dentistry. And so, you know, the reason I'm showing these slides is to sort of think, do you want to get involved in this? Which bit of this do you want to get involved in? So that's about extending the kind of public health roles of community health care settings. If we move then to top right, we've got genuine participation. And this again comes through strongly in our work. This is about putting the voices of children and young people at the centre of policy making about services or decisions that affect them. But as my colleagues were reminding me this afternoon, really thinking about, well, that's not enough. You know, how do we actually get system change? You know, it's one thing to get voices. It's quite another thing to act on what you've heard and to listen properly to what people are saying. So that is the genuine participation strand. There is a strand on enacting health learning pathways at local level. I'll tell you a little bit more about this as we go through the lecture, but Didier has been particularly active in that, going to Korea to enact a declaration. So we'll come back to that. And the last one, but definitely not least, and something that we have, you know, has been strong right from the beginning, and of course is UNESCO's mission as well, is to build healthy and resilient schools, to make sure that schools are foundations for well-being in children and youth. So that kind of sets the scene. And what I hope to do is I'm going to try and bring the health literacy and give you hints about these programs. So look out for these circles because they will pop up on some of the slides to show where I think the health literacy journey links to these programs of work. But we're going to start with a quiz, okay? So I don't know what your background is about health literacy, and I've actually borrowed some questions from a quiz that's from one of the US health agencies. North America, I went to North America at a good time. The health literacy was exploding at the beginning of the century in the US and Canada, and that's where I first got exposed to its possibilities and to its theories. But let's have a think about this. So limited health literacy is associated with maybe higher mortality rates, lower levels of health knowledge, greater use of inpatient and emergency care rather than perhaps primary care, poor medicine adherence, a combination of B and D, or all of the above. Now I'm going to reveal the answer. I hope you've got something in your head. Is this going to be the answer that you would have given? Well, don't you think all of the above usually gives it away? Okay, so all of the above. And this is an evidence-based question, you know, so there is evidence to show all of these connections, these associations with low health literacy. The second one, you can tell how health literate a person is by knowing what grade, it's American, I'm sorry, what year he or she completed in school. Okay, so you can contemplate, talk to your neighbour about whether you think that's true or false. The right answer will be revealed. There's evidence that that is false. And, you know, I can give an example about this. that I've thought about quite a lot, which is, you know, you can have a member of university staff who's got lots of qualifications, as my mother would say to me, you've got loads of qualifications, no common sense. And, you know, they've never interacted with the health system, you know, fabulously, have always been healthy, and all of a sudden something happens, they're thrown into a crisis, and, you know, their health literacy could be low, you know, their ability to navigate that system might be low. Contrast that perhaps with somebody who's, you know, gone through school, didn't really want to go on to further education, but now has a family and children. The birth of a child is often a place where, you know, your health literacy will go up immediately because you are navigating those systems. So, you know, this the links between one and the other are certainly very complex. So then, which of the following skills are considered to be components of health literacy? Okay, so A is about numbers, reading skills, speaking skills, ability to actually understand what is said, writing skills. Yes, you guessed it. I know, you were ahead of me on that one. All of the above. And, you know, the numeracy bit is quite interesting. Hold that thought for a few slides. So it's about more than reading and writing. In fact, I wrote an article for the Pharmaceutical Journal, Health Literacy, more than reading and writing. It's lots of things. And then what do you think about this one? Being anxious affects a person's ability to absorb, recall, and use health information effectively. Do we have the trues? The falses? Oh, there's a consensus here. Indeed, that is true. There's some interesting psychological background to that as well, I would say, about Piaget and cognitive development, which you can ask me a question about if you really want to later. But definitely anxiety and something catastrophic happening to you affects your skills, even if they're usually good in good times. So what is health literacy? I've got you through the quiz, but not really told you what it's all about. Again, it depends how interested you are and what you know about what you've already been exposed to. But this is actually a really interesting toolkit put together by the World Health Organization Regional Office for Southeast Asia. And its take on health literacy is two things. It's the personal characteristics and the social resources needed to access, understand, appraise, and use information and services to make decisions about health. So there are several definitions of health literacy, but what I think resonates with me about that is that there's something about the person, there's something about the system, and it goes right through from accessing right through to actually using the information that you've got. So, or as it says here right at the end, enacting your decisions. And at the end of the day, that's one of the most important things about it. So why should we care? We care because, and this is relatively recent numbers, is it 2015? Yes, the paper was published in 2015. So 43% of adults aged 16 to 65 do not have adequate literacy skills to understand health information, and 61% of adults aged 18 to 65 do not have the numeracy skills to routinely understand health information. I can't leave this slide without calling out Health Education England on, if you're going to talk about health literacy, make sure you can spell the word out. Okay. So with something for everyone, hopefully in this talk, I'm going to tell you something about the different models and the different theories about health literacy. And there's a timeline here. So we start in the 1970s with an author called Ruth Parker, and she got into something called functional health literacy. And this really is about the reading and writing. And there were quite a lot of classical studies that sort of coined the phrases, and the tools that they were using really for doing research. It wasn't really much to do with clinical practice. And you can see some very impressive names of measures, these acronyms like REALM and TOEFL and things like that. So this was the beginnings of health literacy. And then we move into probably my favourite model of health literacy. We can all have our favourite, which is a tripartite model, a three-part model by a guy called Don Nutbeam, who was actually the head of public health at the Department of Health around the beginning of the last, around the turn of the century. And he put forward, and I'm going to go into this in a bit more detail with some data from my research about this kind of functional health literacy, critical health literacy, and interactive health literacy, three parts of a whole. Again, just wait a couple of slides and we'll go a bit further into that. But that wasn't the end of it. The evolution continues. And so we get to multiple literacies with Zarkadoulis, Pleasant and Greer, where they start adding in things like scientific literacy, or civic literacy, or cultural literacy. And one of the best explanations for that model is around breastfeeding, perhaps, you know, sort of having the scientific literacy for thinking, you know, for knowing that natural breast milk is the best start for baby. The civic literacy might be thinking about where can I go in town where I can actually breastfeed, and the cultural literacy, you know, how are people around me, family and friends going to react to breastfeeding? So, you know, I think that's, so you can see how these things could develop. And then we get, of course, because we're well into the noughties by this time, if you're watching the timeline, into e-health literacy. So, you know, recognizing that there are plenty of online tools, online channels of information, and Norman and Skinner put together the e-heals scale, which is that lovely flower here. I'll give you a close-up of the flower in a moment, but one of the things to notice about this is about a movement. So in the 1970s, it was very much an individual focus. It was something, if you didn't have health literacy, you were at risk as an individual. It was all your fault and it was all on you. Whereas you find that over that 40 years or so, what we tend to think now is more of it as an asset to be built, a capacity to be built. And it's not only of a person, so it's moved away from that individual focus to thinking about systems and really to thinking about the community. So, and where will it go next? Well, I'll give you a couple of things near the end, which further complicate this picture. But before we leave, it's a very pretty flower. So you can see here that in the e-health literacy, you've got health literacy, traditional literacy, numeracy, computer literacy, media, science, information, and a lot of these things are actually taught in schools, but possibly not joined together like that. Kind of looking at my friend Suzanne in the audience here, who knows the curriculum back to front from her days in Education Scotland, and you know, it's how can we bring all these things together? So let's go to the nut bean model, because as I say, it's my favourite, and I was very privileged to do some research that I hope is going to illustrate quite nicely each of these themes. So the functional health literacy, like Ruth Parker before him, is this ability to read and write. Then there is an element of critical health literacy, which is, okay, so you've got some information, how do you critically analyse it to get a bit of control over your life events and situations? And then you've got the interactive health literacy, which is where you can derive meaning from it and apply it to your changing circumstances. So let me tell you about a study that I did. I was privileged to do it because I got a chance to do some focus groups, lots of focus groups, some in upstate New York and some in the UK, across the UK actually, including Bradford, Scotland. I went up to Scottish schools and did a lot of focus groups with young people aged 11 to 19 and single sex groups, so boys separately to girls and roughly the same age in those groups. It's, you know, sort of like it's good practice to keep the age ranges quite narrow because there's such a variation and development over that critical period of 11 to 19 years. So what I'm going to show you is some examples that I think reflect these different types of health literacy based on the exercise I asked them to do, which was to sit in a classroom with a computer and to have somebody who was sitting at the keyboard, one of the group, and the others to basically ask them to find some health information, something, anything they wanted to find. So it was definitely a journey of adventure. Well, we'll see from some of the examples here how they reacted. So functional health literacy. Imagine the scene. B is sitting at the keyboard. Right, what do you want to search for? E starts, oh, symptoms for gonorrhea. Let's impress the researcher here. Okay. B, how do you spell it then? E, oh, I don't know, G-O-N-E-R. No, it's G-H, definitely, G-H-O-N-O-R. And then this guy hands from the back, oh, look for something you can spell. 16 to 17-year-old male students trying to look for symptoms of gonorrhea, but they can't spell it, and it wasn't going anywhere fast. Now, I know this was 2001, 2002. And, you know, our search engines have come along a long way since then. You know, you can speak into it, it gives you, you know, do you want to look for this or that? But even so, this is technical stuff. This is complicated spellings. And I think the other thing, if I then bring another one up, which is another UK student, 15 to 16-year-old young woman. Yeah, you don't really know how to spell it. Endometriosis, she was talking about. I saw something about it on television. So, you know, she was hearing the word. And I did actually want to know more about it, but I didn't know how to spell it. So it doesn't even start. The search doesn't even start. So that's functional health literacy. That was one of the strong things I thought came out about functional health literacy. And then if we turn to critical health literacy, there were some interesting conversations went on that were different depending on which side of the Atlantic you were on. And if we were in the UK, this was a group of a male student within a group, 16 to 17 years. So they were looking at the screen and he was saying, well, if you see a logo or something like that, that tells you it's been checked over and looked at by this regulatory body, are you impressed? 16 to 17-year-olds talking like this. You don't see that, then you know you can trust the site. And then, of course, he reverted to the health brand of the UK, which is the NHS. Oh, the NHS. Yes, you know that you can trust the site. And what was interesting about that was when I was talking to the same young men and young women in the States, you know, it's like, oh, Encyclopedia Britannica or National Geographic or things like that. So they were turning to brands, they were turning to a shorthand for things they could trust, but they don't have the same kind of NHS big health machine that puts out information that they knew they could trust. So for me, that was interesting about critical health literacy. And they were very, very sophisticated at looking at web addresses. You know, they were looking at, they knew that .edu in the States meant it was a university. So, you know, they were sort of saying, oh, this one looks all right. And then there were other comments like, oh, I like the bland sites when it comes to health information because they're not trying to, you know, attract me or entice me, you know, so things that go against the grain really for teenagers. They saw health as something different from other things that they might search for online. And then if we talk about interactive health literacy, so I was trying to figure out, well, how do they actually put, you know, they find this stuff, what do they put into action? And this, again, was a young woman, 17, 18 years old. So, and it reflects some of the things that we've been talking about today in our other discussions, you know, but I'd use it, well, just for the beginning or the first stages. If I need to buy a medicine or I need to consult the doctor, just to find a bit out and then go and see somebody in person, you know, before doing anything. So recognizing that there is a linkage, it doesn't operate in a vacuum, you know, that there might be things that they have to do, people that they have to see to put it into practice. There was a very enterprising GP, general practitioner doctor, whose surname was Elliot Binns. So Dr. Elliot Binns did 2 studies in the 1980s, about 15 years apart, I think they were. And he basically, he'd probably not get ethical approval for it now, he wouldn't be able to publish it, but he asked everybody who came into his practice to tell him where they'd got their information from before they came to him. And his big conclusion was that people had gone to at least 2 other sources of information before they got to him. So it's a nice little study, and it was quite, you know, sort of like steady over time. But it just goes to show, you know, we are not the first people as health professionals that, or sources that our patients have been to. So it's a web of information sources, no pun intended. And then another piece, actually, I'm going back to my PhD here. My big conclusion from my PhD, although it kind of took on a bit of a better title, was I went to Peter Noyce. Any of you who remember in the room, Peter Noyce, I was very privileged to have him as my PhD supervisor. And it was the end of the day and I went into his office and I said, well, you know, it's like they've got this mental medicine cabinet in the head. And he went, oh, you know, so you mean something like health repertories? And it's like, yes, that sounds much better. But the concept is here. I think that the research that I've done with young people, and the reason that we chose young people in the first place was, as Peter and Judy Cantrell, who was my other supervisor, said to me, they said, well, if you're going to ask people why they started doing something, with young people, you've got half a chance that they can tell you what they remember, that they can remember where they first got the information from. If you ask anybody older, they'll have no idea. So what was interesting about working with young people was charting their journey, their independent health journeys. And one of the things that I realised, even working with young people, was that there's some fairly sophisticated and nuanced things going on in their head. So they realise perhaps that they've got a symptom. So each of these boxes in my beautifully complicated diagram represents a symptom or a condition that they might have encountered in their life. The arrow going into it maybe says who gave them the information that they're using in the action that they will take to try and make themselves better. And each of those boxes contains details about how they know that they've got symptoms, what product choice they might have, or indeed a choice of a non-medicine, you know, some home care, staying at home, honey and lemon, everything. And some of them even had contingency plans if the product didn't work. And this was very nicely shown. We were talking earlier about acne, a conversation that I had with a young man who'd come to the pharmacy to buy a face wash that he'd seen advertised. He'd already tried one face wash that wasn't really working for him. And not only could he tell me every sentence of the advert, because I actually went back and watched the advert that he was telling me about, and it was word perfect what he told me. But he also said, but if this doesn't work, I'm going to have to go to the doctor and get antibiotics. So not only was he in the middle of it, but because one of his friends had had quite bad acne and was taking antibiotics for it, he'd already got, you know, sort of like he'd already figured out what his next step would be. It was incredibly nuanced, and you can just imagine what's going to happen as you keep moving through life's journey and get more and more information and skills. And I took the slide out and I put it back in. It was something that I was playing with around the turn of the century when I was trying to think about the place of the internet within the other information channels that young people were using. And I kind of came up with this quadrant diagram where we have, you know, lay channels on one side on the left, we've got expert channels on the right, and then you've got expert personal channels talking to somebody, or an impersonal where it's a bit like you reading something, and then lay personal and impersonal. And then I realized that the internet just sat at the middle of all of them, you know, and was somewhere maybe you could go in different directions because it had the elements of you could talk to people or not on the internet, and that the source of the information might be lay or medical and professional. So it was just, you know, trying to bring these things together and just recognizing the complexity of what people do, and really the quite stunning skills that they develop over time without much formal teaching. So if we take a health learning pathway, we'll be talking today about lifelong pathways that people might follow in cities or in local places. The only thing that you need to, you know, this is busy. I wrote it for Didier because I was trying to give him an example of something that I was talking about. So it's fictitious, but it's basically about Anne, if you like, a young woman aged 29. She's working as a retail assistant. She's living with a partner, one child, Rose, age 3. She was diagnosed with asthma at the age of 11, and she takes regular medication. So for this young woman, what would be some critical points in her timeline, and where was she getting her health information from? So you can see that, you know, an asthma diagnosis at 2005, that's going to bring in all kinds of different health information sources for her and her parents at that point, working together, or basically parents perhaps just giving the medicines. You know, life events, first serious boyfriend, okay, let's think about contraception. You know, these things aren't just done in a vacuum. When she leaves the parental home, after the conversations that I had with university students about leaving home and the impact of not having your mum's medicine cabinet anymore and not being able to just talk to mum about what you were going to do, it's immense. And then the birth of Rose, these are all critical points in her timeline. And you can see the diversity of the health information that she gets. And, you know, if you identify with any particular point on Anne's timeline, you know, she's thinking about all the different healthcare people, but you're thinking about like mother and baby groups. Oh my word, the conversations about medicines in mothers and baby groups, you know, there's so much going on there. How do you sort it all out? And of course, there is the school element of this. So talked about those critical points where she might become a lot more health literate along the way because of things happening. And also very relevant to our work in the chair, the impact of the school years, or the opportunity of the school years. And again, talking to my colleagues in education about Suzanne, it's really struck me about that longitudinal, that immense period of time that you have early on in life, where there's so much potential for equipping young people with health literacy skills, as well as many other skills. Now, I'm excited about this. It is in French. Okay, that's the first thing. I've not totally gone mad. and done something. But what you will see, and the francophones in the audience will be able to see, is that this is a pathway, and this is some exciting new work that is going on in Clermont. So Didier and my excellent colleague Valerie are working with schools, with pharmacists, with different community organisations. And what they're trying to map out, chemin de santé means like health pathways. And so we're mapping out here from the age of 2, so each of these are age boxes, what are young children finding out about, assimilating for themselves as they go through this pathway, through nursery school. The blue boxes show things that are, you know, sort of like maybe interventions that the local authorities might make. So bien-être was well-being, and then emotions. You can see there, sommeil is sleep. And then we move up through physical activity, food, and screens, les écrans, and then dents, about the teeth and things like that. So they're moving through very naturally, you know, assimilating all this knowledge, and we're just trying to make it visible and trying to see where people can amplify that. And you can see the lady on the left-hand side is talking about the pharmacists there. So these are posters that are going outside nursery schools and also are going outside pharmacies, and the pharmacies have been very enthusiastic about trying to make these links with families and to amplify. So what's going on in school? How can we, you know, sort of like validate that and value that? And equally what's going on at home. So it's bringing all these things together in a very exciting way. Let's just move into another of our areas, is thinking about schools and health literacy. And this long-term opportunity that they have is not just through the health curriculum, of course, even, you know, the physical, the built environment that they see every day, including the vending machines, you know, and and the things that surround the school, the fast food vendors or otherwise, the green spaces, you know, this all helps, you know, with the health literacy, you know, just reflecting on the environment, and the commercial determinants of health, if you're into that particular thing, are relevant here. But then you've also got the processes of learning, and there's a lot of things that will come through to children, even without you actually telling them concrete things about health. So they might look at the way that people respect each other or don't within the school, and the processes of learning. You know, the culture, the idea of belonging, the leadership is so important. It comes from the top. So it's not just about what they're actually told. Does the school model health literate practices? Again, it comes back to the products in the vending machines, the products in the canteen. And does the school work with local health providers to try and increase and embed that health literacy within the school practices? It's something that I would love to see, and it's definitely something that we'll be exploring with partners over the next few years in the locality and beyond. Because health and education are mutually beneficial. We've had the chance this year to work with UNESCO, UNICEF, other UN agencies on this report, Ready to Learn and Thrive. We ran a webinar for them. If you come to our UNESCO Chair website, all these things are on demand, because Sylvia puts them all there with her magic and edits all the webinars that we do, including this one. It'll be there soon. And, you know, it's, you know, the fundamental foundation of that is that students who feel well, that is, they've had enough to eat, they've had enough sleep, they are ready to learn, they feel valued, they feel they belong. And students who get a good education tend to have better health outcomes through their life and for their families, and primarily because they get a decent job, they get into decent housing, they've got the means to, you know, and they've got the knowledge and the health literacy skills to know that their kids need vaccinations, and, you know, to bring their families along with them. So schools and health literacy as part of our hubs in the community for promoting health literacy are super important. And in line with our, you know, big theme on genuine participation, I think that this recent, it's fairly recent, 2021 NICE guidance about the experience of babies, children and young people in healthcare has elements in there which are certainly to help their health literacy and to build their health literacy. But, you know, for me, this could be any section of the population. And certainly through my journey through young people's health, I've seen many people who've said, if we get it right for young people, we actually get it right for everybody. So it's actually a really good, you know, investment in time, because things like, you know, ask me if I understand things, involve me, respect me, talk to me, explain things in a clear way that I understand, help me understand. This is all something that we can use to amplify and work towards better health literacy for our children and youth. So I'm well impressed with NICE on this one. It is stellar. Now, health literacies in cities. You mentioned that Didier went to Yeonsu in Korea in the pandemic. It was a very interesting meeting. There weren't many people there. And but they felt that there was an imperative, and I don't think it was a coincidence really, because if you think about the pandemic, and I think about Salford where I live, there was quite a lot of city branding around health issues, you know, around COVID, you know, so things out there in pink, because everything in Salford is pink, the signs are pink if you've ever been through Salford. And, you know, it'd be things like keeping your distance and, you know, but there were things, you know, put around bollards and, you know, sort of like these a real effort at messaging and building, you know, good, healthy, respectful practices in the city. And UNESCO has a global network of learning cities, and Claremont, which is where Didier is, they are already a learning city and have been for some years. But fabulously, Kirklees has become a learning city as of last year. Nothing to do with us, I'm sorry, we can't take the credit for that, but they're part of this UNESCO network, and we're hoping that over the next few years we'll be able to develop that relationship as well. But this enactment guide for learning cities gives the leaders of cities some ideas for how to increase the opportunities for lifelong learning for health. And they talk about health literate cities in one of the sections of the enactment guide. So this is recognising at the highest political level the importance of becoming and remaining health literate. It's committed to intersectoral work across government, because it's going to take a joined up approach to be able to do anything sustainable. And it should provide individuals and communities with skills and knowledge, because healthy people and communities are one of the key assets of cities. So there is a lot in it for them if they invest the time. So the enactment guide is a way of cities looking at self-assessing where they are and trying to take steps forward, and health literacy is one of the things. So if you think about that idea that, you know, reflecting this movement in the literature from a very individual based approach to kind of systems, communities, and this is really saying that the responsibility is not totally on the individual, but that the city has to think about how it can, as an entity, become more health literate. And, you know, I think the important thing in the first point there is making the healthy choice the easier choice. That is the way it's going to happen. You know, it's, I know in young people's health, there's been a real pushback against the individual choices made by individuals. It's about the systems. It's really about things like smoking bans, if you think about it. You know, that was when the great leap forward came. It was legislation. It was mainly that people couldn't smoke in certain places. It was never going to be done by a lot of individuals spontaneously changing their behaviour. You want to make the healthy choice the easier choice, the only choice. And that's where change will come. And it's about private sector and many voluntary organisations, also about measuring. We were talking earlier today about this idea of planning, enactment and monitoring, and that's where the accountability comes in. So hopefully, I'm very proud of Didier and his work on this, contributed in a very modest way to it, but definitely looking forward to making more and contributing to the way that we play out enactment. There's more to come. So I thought we'd have another quiz, because I've been talking for too long. And this is actually a health literacy tool. It's quite an interesting one. It is freely available. If you do the newest vital sign, the whole tool comes up, and it's quite an interesting talking point. You're probably quite familiar with the format of it, that it is about a label on a food stuff. It's a bit American again, and I apologise for that, but you know, that's the way it is. So you'll see things like cups instead of whatever grams or metric that we would come up with. But I thought it would be interesting. I thought you might like to measure your own health literacy. So if you've got a pen or paper, or you want to open a notes page on your phone, then we will work through this together. There's 6 questions, so we're not going to be here too long doing it. And you can decide where your health literacy is, because we shouldn't make any assumptions you may not know, I've already said this to somebody who, was very high up in pharmacy and said, I think it was in 2005, there was a white paper about improving health literacy called through community pharmacy. I do not think it was very well known at the time, but it actually has some amazing things in there. And one of the points that it makes is about not assuming the health literacy of your staff and making sure that your staff were building the health literacy and then would be able to support other people to do so. Anyway, I digress. Let's go back to the newest vital sign. So, are you ready? Good, I know it's late. If you eat the entire container, how many calories will you eat? I'm going to give the answer one question at a time. So when you all kind of look up at me, I'll know that you've had a go. Okay, 1,000 calories. I'm going to look at you all to go for the people who go, oh, yes, and all the people go. I'm keeping track too. 1,000 calories. Okay. If you were allowed to eat 60 grams of carbohydrates as a snack, how much ice cream could you have in this pot? Okay. 1 cup, 2 servings, half the container, any of those? People aren't looking too upset at this point. We'll carry on. Your doctor advises you to reduce the amount of saturated fat in your diet. You usually have 42 grams of saturated fat each day. Fat, there's the clue, which includes 1 serving of ice cream. If you stop eating ice cream, how many grams of saturated fat would you be consuming each day? Ooh, who got 33? I found this one tricky. Oh, I've got some people looking very self-satisfied. Amateurs, yes. 33 grams, okay. Then question 4, if you usually eat 2,500 calories in a day, what percentage of your daily value will you be eating if you eat 1 serving? Oh, 10%. How are you doing? Doing all right? You're keeping track of how many you've got right? I should have told you that because that's what it will come down to in the end. Okay. I'm sure you've all got 4 out of 4. Right, now pretend that you are allergic to the following substances: penicillin, peanuts, latex gloves, and bee stings. You poor soul. That's quite a lot of things to be allergic to. Is it safe for you to eat this ice cream? Lots of serious shaking of heads going on. No, of course it's not. And why not? Because of the peanut oil. Thank you very much. It contains peanut oil. Okay, so we're now at the end of the questions, and here is how the people who have developed this would score it. So they say that a score of 0 to 1 suggests a high likelihood, 50% or more, of limited literacy. Okay, so it's complex, it's not straightforward. 2 to 3, there's a possibility of limited literacy, but 4 to 6 almost always indicates adequate literacy. So I can imagine around the Christmas table now you're going to be pulling out the newest vital sign as something nice to do while you wait for the Queen to come on after lunch. Oh, okay. Thank you. It's getting late. It really is. I mean, come on, I've had 2 years of a king and I had how many? We won't go into that. Okie dokie. Yes, the king. Sorry about that. Okay. So to kind of, you'll be relieved to know that we're coming towards the end. And but what I did want to talk about was a bit about the future and about, these new technologies and health literacy. And so I was asked as part of an adolescent health conference last year to argue that social media was good for young people. And my friend got the probably easier thing of arguing against it. But I thought, well, there must be something good about social media. There's got to be something good. And there's actually plenty of things that are good. But what I said about it was I said that I think that good social media use is a skill like driving, okay, that it has inherent risk, that it is usually a means to an end, not the end itself, although I love driving, so I don't actually fulfill that, I just drive, okay. It requires skill and focus to be able to do it well. You are in charge of something that could seriously wound other people. So you have to learn to harness that power, and that it should not be done under the influence of substances or friends. And having a lad who's learning at the moment, it's like, that is definitely true. So with that kind of in the background, maybe that is where social media is for me and young people's health, then perhaps we need an advanced social media qualification. We need to get under the bonnet of that social media, because social media, and I'm going to take this through into AI in a couple of slides time, is, it's understanding how it works. We are, when it comes to technology, you use things, I use things very superficially, and we're not really thinking about the way that things are generated. But I think getting under the bonnet to understand algorithms, and understand that it's not just random. What you're getting through your social media feed is something that certainly children, young people, and most of the rest of us need to understand. And I'm going to put on our website, I'm going to put up a lot of the references for this talk, and there's a great one by, is it Social Sprout, which is about everything you need to know about social media algorithms. So, just understanding how decisions and things are made. I think there's reasons to be hopeful that young people feel that information about health and well-being is different from other information that they might get from social media about celebrities or about music or clothes or something like that, so that they will, from the things that I showed you from years ago about the internet, that there is a kind of healthy skepticism that will come in, at least for some young people, but there will be others who perhaps do not have the same level of critical analysis applied to it. And that I think that this idea of cross-referencing whatever you're getting from social media sources with other information sources, getting a second opinion, or talking about it with your friends, is again one of the strategies that young people do use to keep themselves safer in matters of health. And I think that they also have to be very aware of commercial determinants of health, about the people who are out there to get them to do things, the influencers of the influencers, the product placement that's going on. It's not benign out there. It is not random that your influencers are using this kind of vape or, placing these substances. There are people influencing them just as much as they're influencing you. So I think that understanding what's under the bonnet is crucial. And when it comes to AI and health literacy, just obviously this is exploding. AI is just exploding, and the commentators are exploding. But this is a very recent August blog by the King's Fund, talking about whether AI can help put people firmly at the centre of their care. So, can it give people more health literacy? And they're certainly saying that there's significant improvements to health and care service delivery through AI development. But if you go on through it, the last part of it says, but a greater shift could be brought about if they are designed and developed so people are more in control of their own health, their well-being and self-care. So again, it's this idea of the individual but interacting with the system, and that both individual and system need to be, need to get the benefits of AI. But I am a devotee of the blog The Rest is Politics. I don't know whether anybody else listens to it. It is Alistair Campbell and Rory Stewart, and they've been talking a lot about AI, and they had this guy Mustafa Suleyman on recently and interviewed him. He's a friend of Rory Stewart, but he's in Silicon Valley. He is a British man, and he is one of the pioneers of the AI platforms, and their particular AI offering is called Pi. And what he was saying and again, I'll give you some YouTube clips about this, with a Washington Post interviewer, was talking about everybody having a personal intelligence in the not too distant future. He's certainly talking like 3 to 5 years, not next year, he said, but 3 to 5 years, a bit like Bill Gates said about the personal computer, and everybody poo-pooed Bill Gates, as I remember. I don't think people will poo-poo what this guy is saying, but you can see the interface here. If you go and search Pi, this is it. And I've put the personal intelligence green blob in the middle of it, but it's just a screen with a chat box at the bottom. But he says in this particular interview that how they've developed Pi was very much to look at the empathy, you know, to really look at the way that the conversation is conducted, to try and make it as reactive and as empathetic as possible. So it is coming. And if you think about this kind of lifelong learning for health pathway, he calls this personal intelligence like your chief of staff. Yeah, very American. But, you know, the idea is that you won't be Googling anymore to find a break in, you know, Dubrovnik. It will be, you'll just tell them you want a break in Dubrovnik and it will book your hotel and it will book your flights. And, you know, sort of like you will be able to instruct this personal assistant. And you can see how you might have those conversations about health. You might say, I don't feel too well this morning, and it's booking you a doctor's appointment, or it's ordering your medicine from the local pharmacy. All of these things are possible. But sounds very good, but there are things, again, under the bonnet that I think are the flip side of this. So I went and had a look at another blog by a guy called Peter Graff, and he was doing a TEDx talk in Sonoma County, hence the barrels behind him. He's in wine country, the lucky thing. Anyway, but he said some very interesting things. So he also is an AI developer, and he's quite worried. You know, they all have their, you know, concerns about it. But the particular worry that I think is relevant to us and thinking about us, and there are, you know, people who are interested in data and everything in the room, is if you think about our AI tools at the moment, they come from this large language model, which basically means that they are fed with everything from the internet. Now, if we feed them with everything from the internet, for as long as the internet's been going and everything retrospective to that, we're not going to come out with a perfectly unbiased data set. There will be themes within those data that perpetuate inequalities and inequities that have been going on forever. So the last thing that we really want is for our AI tools to reflect everything that we're trying to mitigate from the past, however X years. But I think that this is the point at which we have to say, well, what are the training data for these tools and how can we optimize the training data? We do not want to just feed it with everything that's ever been on the internet. The next point he brings out about how needing explanations for how AI works. We're very happy to put things into a black box and just see what gets spat out at the other end. And he was talking about a particular thing that they were very confused about, because they showed an AI tool a picture of a husky and it kept saying it was a wolf. Okay, so he kept showing it the husky and it kept saying it was a wolf. And it's sort of like, well, why is it saying that it's a wolf? Well, apparently this AI black box was saying it was a wolf because the dog had snow behind it. And all the pictures that this AI thing had ever seen of wolves was with snow behind it. So of course, if it's got snow behind it, it's a wolf. You know, so we need to know how the decisions are being made, so that if there's something biased or wrong in those decisions, then we can see it at that point. It's not that we just accept what goes into the black box and what comes out of it. And so I think that, you know, it's healthy to think about, you know, the fact that AI is a tool. It shouldn't be a substitute for decision making. Guys like him are just saying, why would we as humans want to take away the only, you know, our ability to make decisions? It is what makes us human. So, you know, it's about having this healthy tension and healthy balance and, you know, using it for the benefits. And who will be accountable for what AI does within health? Who is going to do that? So conversations, we're right in the middle of them. It's a good time to be thinking about these issues. So what should we do? Well, we should think about local action. This is a Public Health England paper from 2015. It was done in conjunction with the UCL Institute of Health Equity, Michael Marmot's group. And, you know, thinking about the fact that we need health literate individuals with health literate systems, and hopefully that's going to give us health literacy across England in this case, and reduced health inequalities. And, you know, this circular diagram talks about targeted action to improve the health literacy of low literacy populations. So this is Michael Marmot's kind of targeted universalism. You know, it's kind of there are interventions that will increase everybody's skills, but that you then need to target to the people who need it most. So that's it, the broad action to make health and social care systems more health literate themselves, and broad action to improve the conditions in which people are born, grow, live, work and age, because we can't do all of this from healthcare on our own. It is a much bigger game in play. So I think that those hold strong, and that I would offer them to you as some things that we could do. Things like making further education more accessible, combining those lifelong skills training with health, specific strategies for the disadvantaged socioeconomic groups, demonstrating medical instructions for those of us in the health industry, you know, just really working through people and telling them the jargon, as well as trying to simplify the language, because they're going to see the jargon on the internet, through social media. We want to increase the health literacy. Using champions, ensuring that health materials are clear, and writing in plain English, in this case, in plain local language in others. Develop our health literacy, think about those critical life events, invest in schools and colleges, intersectoral working, and in the end, these lifelong health learning pathways can give us a useful framework. So thank you very much for your attention. Thank you for joining us on this launch day. We've got packs here and pins, these unique launch pins that you're very, very welcome to take away to show you're part of our community. And please use our contact details, and very shortly we'll make you aware that the materials are all up and running on our website. Thank you so much for sticking with it.